Kia ora, bonjour tout le monde, good evening. Haven't you done well getting here? Whether you'll leave, I don't know, but getting here, well done. That was great, thank you, Nicole. That was really good because it didn't sound like an obituary. The older I get, if I get introductions, the more it sounds like an obituary, and I just wonder whether I should be checking my pulse. So what I'm going to talk to you about tonight is about using technology in mental health. I'm going to describe some examples of that, and I'm going to describe some of the work that we've done and some of the work that's been done elsewhere. And I'm going to tell you a little bit about the advantages and limitations of that, and end up with some recommendations around policy. What I'm not going to tell you is that technology is the answer to everything, because it's clearly not, especially in mental health, where relationships and managing relationships is really the core of the subject. So technology is not something I'm promoting as saying is the solution to everything. It can be a useful tool. So that's what I'm not going to say. This is what I'm going to say. So, psychiatry in fields, psychotherapy in fields. Is this the psychiatry of the future? Technology, talking to a computer screen. We can do this now, actually. As you probably walked in here, you saw some suites just around the corner which have got, I think, the Bell logo on them, which is the Ontario Telemedicine Network suites, so we can telemedicine to other telemedicine sites. But also now there is the capacity to use that setup there to telemedicine and to hold conversations with you at home. It doesn't use Skype because we can't use Skype because it's not very secure. I don't know if you know how Skype works, but basically Skype works by bouncing off lots of other people's computers. And it's not very secure. So you know what it's like in Canada, where privacy trumps everything. Yeah, so you can't use it. But there is now a way of getting psychiatrists beamed into your living room if you really want that. So if you really want that. So that'll be a technology coming to you soon, so you probably won't have to come here very, very much more. But I'm not going to be talking about telemedicine. I'm not including that in the technology because that's really a separate talk all of its own. And of course, technology is not new. We always think that we're in a technological revolution, but of course, electricity is fairly new. About 100 years ago, turn of the 19th century, beginning of the 20th century, one of the common diagnoses that would be made in a building like this is neurasthenia. You read the contemporary accounts about neurasthenia, it's really all about fatigue. And one of the treatments, there's a mere Witchell cure. That was the double-barreled name of a man who promoted this cure. Basically, the cure involved lots of rest and baths in which you dropped electric currents into. And the cutting-edge technology, after people stopped having lots of baths, is to have the electric belt around your waist. And this is an unusual treatment in mental health, and it's actually focused on men, this particular one. Neurasthenic nation, America, wear your electric belt, and get low-grade electric shocks to make your neurasthenia better. Is anybody wearing one of these? No? Star Wars top? No? You can buy these. I've seen these for sale around here. These are the old mere Witchell devices where you drop those little golden plates. You drop them in the bath, and it sends you electric currents. You get better. Probably because you have to move quickly to get out of the bath. It's like exercise. Steam baths. Yeah. Steam, generation of steam on a mass scale. These are people in asylums. I'm not too sure where this picture was taken, but it used to be a treatment in the older asylums as a way of calming people down. What's this? Oh, cutting-edge 1970s technology, the fax machine. We still use it, believe it or not. We're really good at using cutting-edge 1970s technology. So, that's one historical perspective. Here's another historical perspective. Healthcare has been through three revolutions, really. First revolution was basic understanding of physiology, anatomy, and the discovery of antibiotics, which really changed medicine up to the mid-20th century. Discovery of penicillin, game breaker. Discovery of how the body works, how to do effective surgery for many things, bit of a game breaker. The next phase of medicine was the discovery of stents, randomized controlled trials, transplants. That took us up until the beginning of the 21st century, because those tools, they were new devices which we were able to be discovered using new technology, new ways of thinking about things, new ways of demonstrating effectiveness of treatments. And now, what's the third wave? That's another way of thinking about it. In the third wave, everything's purple, just in case you're wondering. And it's driven by many things which are happening in society at the moment, which is about the dissemination of knowledge. I mean, my job as a doctor has changed. I qualified in 1984, and then I knew more than my patients. I don't anymore. I'm much more of a broker of knowledge and can give advice about what may or may not work, and a deliverer of care in a way that was quite different to when I qualified. I don't know anything about medicine or psychiatry anymore. I don't have to, I just look it up. I've forgotten lots. But what I do know is what's important. So it's driven by citizens, it's driven by knowledge, it's driven by personal computing, focusing on patients. It's about the dissemination of power, the dissemination of knowledge. And I think Nicole talked about personalized medicine. Well, personalized medicine is often spoken about in relation to genetics and genes. But of course, habits are quite personal as well. In many ways, our habits define us more than our genes. And our habits are often amenable to behavioral change, which can be supported by technology. So, that's a historical perspective. How does that fit into the current environment? In the current environment, there's lots of challenges. In the Canadian environment, one of the big issues is about access to care. Healthcare organisations harm people. There's, I don't know how many people know about the 100,000 campaign. It's a bit dated now, but in the 90s, they found that there's 100,000 deaths due to adverse events in American hospitals, US hospitals. So they thought they might want to try and reduce that. So they had a campaign to reduce that, which was has been reasonably successful about reducing medical errors. There's a lot of waste. Waste in terms of physical resources, waste in terms of time. There's a lot of people, it has been argued that there are a lot of people in a system like we have in Ontario, which is based on health professional billing for their time, who do an awful lot of work which doesn't make any difference. Because the financial drivers drive you to see lots of people quickly. And you could say that a lot of that is doing stuff which doesn't make a big deal of difference. There's a lot of variation in care. When I first came here from New Zealand, there's lots of variation. I don't think I'd ever seen quetiapine or Seroquel prescribed before. Here, everybody I saw had it. Even people I didn't see had it. So there's variation in drug prescribing. Polypharmacy is a feature of medicine here in a way that it's not elsewhere. May or may not be a good thing, but the point is it varies. If you see me, you'll probably get different treatments than if you see one of my colleagues. It's a lucky dip as far as patients are concerned. It shouldn't be like that. There's inequity. There's inequity in access to resources. And there's not a lot of attention paid to prevention. So the challenges to be addressed are rising need. Now we've inherited a health system which is responding to acute demands for acute crises, but what most people suffer from now is chronic illness. There's financial restraints, and of course there's carbon restraints on what we do. It's increasingly bizarre, I think, to insist that people come to a central building somewhere in town to get their healthcare, unless they need some of the specialised equipment there. If you don't need that specialised equipment, why do you need to come here? Why do we need big car parks? We need to expand here. How does technology react to some of those drivers, to that historical perspective? I've talked a bit about the dissemination of knowledge. One example of technology, one way in which technology has responded to this, is online e-Therapies. Has anyone tried any of these? No, you're all good about it. Okay, I'll show you some. These are essentially psychological therapies, cognitive behaviour therapy, which you can access usually for free online, and the computer does the therapy. And there's been probably about 3 or 4 generations that's just gone through now. The first generation of these looked like books online. You just read them and filled in questionnaires. Second generation, there was some interaction online, and you can learn by gaming, but it wasn't that interactive. It didn't interact with the mobile phone, for instance. And third generation is integrating with mobile phones. A lot of the e-therapies were developed when people still had desktops. I don't know how many people have desktops anymore at home. The only people I know who have desktops are academics, who write papers about people having mobile phones at home. And then there's fourth generation treatments with smart environments and mobile phone and mobile therapists. It's like having a therapist in your pocket. I couldn't actually think of anything worse, but some people seem to like that. So the advantage of online e-therapies is, of course, there's no waiting lists. You start up anytime you like, and you can do it anytime you like and from anywhere. It's a really big advantage. There's no stigma. Nobody knows you're doing it. It can be tailored for specific groups. So it can have e-therapies for men, e-therapies for women, e-therapies for young men, e-therapies for old men, e-therapies for First Nations, for Inuit, for Cree. You can tailor very specifically the e-therapies in a way that you can't with face-to-face therapies. It addresses workforce problems. Why would you want to go and see an expensive psychiatrist like me face-to-face if a computer can do the same thing? Why would any health system pay for that? And there's questions which I'll come on to later on about cost effectiveness, whether it's better in various new treatments. The graph on the right just tells you something about the explosion of interest in this and the number of trials which have been published on this since the start of the 21st century. I should really update that slide. I realise now it's nearly 10 years old. So this is a particular e-therapy that I was involved in New Zealand. It's called The Journal. It doesn't have the website on that. It's www.depression.org.nz. It's www.depression.org.nz. And it's a 6-session online free treatment for treating depression, treating mild to moderate depression. And it takes you through essentially cognitive behaviour therapy. And it teaches you a problem-solving skill. And also talks about lifestyle issues as well. And the way you do it is, does anyone know who this is? I know who this is, and I'll tell you a personal story about her, but not publicly. Anyone know who this is? He's world famous except in Canada and the US. He's now Sir John Kerwin. He's a world famous, except in North America, rugby player. And he suffered from anxiety and depression. And there's actually archive videos of him playing rugby for the All Blacks, the New Zealand national team, having a panic attack when he's actually playing. So he's been a great advocate for mental health in New Zealand, and he has fronted this program, and it's very much part of the National Depression Initiative. This wasn't just a one-off online e-therapy that somebody developed in their bedroom. It was part of a package of measures that you can do in a country like New Zealand, which is essentially a single-payer government health Department of Health and a relatively small, technologically sophisticated population. So this is part of the National Depression Initiative. And what you do, there's 6 lessons. You can't see them all here. Those are the last 3. And you watch a lesson, so it's a video, so you don't have to read it. And he gives you a task. And then you have to plan that task. There's drop-down menus and stuff which come along. And in this particular one, you have to list some problems, and you write a problem-solving statement, which is one of the skills you learn how to do that well. And not on this page, but on other pages, you can link this to your mobile phone and get text and email reminders from John Cohen to do what you've planned to do. So if you plan to walk 2 kilometers that day, you get a reminder to do it from John Cohen on that particular day. So it integrates with your mobile phone. So it's an online. It's a relatively sophisticated therapy which gets away from having to read everything. The difficulty with these sorts of therapies, this is 6 lessons, is that nobody completes them. But people get a lot better, even so. It's a bit like face-to-face therapies. Most people don't complete a course of face-to-face therapy. Really? We did a clinical trial where we offered people psychotherapy, and we had to go through this exhaustive consent process. You have to put time and effort into understanding the consent form. And we did this, and of the people who said, "Yeah, we'll have psychotherapy, we'll have face-to-face therapy, we really like that," 20% didn't turn up for the first session. There you go. So even off the gate, 20% of people aren't turning up just for face-to-face therapy. So it's a bit like that with online therapies. So in this one, this therapy, I think only 5% of people actually make it through to all 6 sessions. But most of the improvement happens after 2 to 3 sessions. So maybe they shouldn't have to go through everything. But it's a particular issue with online therapies like this, is that people often is people drop out a lot. So one of the responses to that is to have somebody to support you. You have an online coach ring you up or text you or email you, say, "How are you doing? Have you done the therapy? Any barriers to doing it?" So they don't actually do the therapy, they're a coach. And the language is quite deliberate because it's a sporting metaphor. People get this, and there's 2 reasons for doing that. A, people get the sporting bit. They get about having a coach and a plan to get over difficult periods in life. But also because it appeals to men. Men buy into the sporting stuff, the coaching metaphor, much more so. And that's one of the reasons why we chose John Cohen for this, is because the advertising agency who put this together wanted to make sure that he appealed to women as well as men. He has cross-gender appeal, apparently. But also because men are quite a hard group to get to, especially for mental health issues in general, but mental health issues in particular. And it's been quite noticeable. GP friends of mine, family doctor friends of mine in New Zealand tell me that one of the things that's changed since this campaign has started is that men will now come into the come into their consulting room and say, "I've got to touch the Kerwins." John Kerwin's his name. "I've got to touch the Kerwins." When we first launched this website, it was supported by TV adverts, quite sophisticated TV adverts. It wasn't, they weren't rubbish ones, they were actually quite good ones. And if I'd had time, I would have set them up here, but quite sophisticated TV adverts which directed people to the website. And in the first year, there were 700,000 people accessing the website. of whom 36,000 logged on to the journal part and started cognitive behaviour therapy. Imagine what it would cost to provide that for face-to-face therapy. Population in New Zealand is only about 4 million, so that's nearly a quarter of the population. That tells you something about the potential outreach of these treatments. Yeah. Once you start doing stuff online, you get really big numbers in a way that you just don't when you see people face to face. And this is just tells you about the National Depression Initiative. There was another bit, which is this bit. It's called the lowdown.co.nz. Just make sure you put in that particular address in Google, because otherwise, if you don't, you end up to a lesbian porn site. Apparently. So I've been told. But yeah, this is the National Depression Initiative. And we did a randomized controlled trial of this in New Zealand, where we offered this to people who've been referred to community mental health teams. The setup, certainly in Auckland, of mental health care is very different to here. Here it's all inpatient beds, no community. There it's all community and no inpatient beds. Access isn't an issue there. There's lots of other issues, but access isn't one of the issues. So what we did there was, when people were referred to a community mental health team, we randomised people and said to half the group, would you like to try the journal with a coach? So we had a coach. And the other group said, we'd just like to follow you up for a period of time, just see how you do. And you see that everybody got better. The intervention group got a bit better, a bit quicker, a bit more better. Because of the size of the trial, it probably is not statistically significant, but it's a difference. The other thing was that, first of all, most only completed 2 or 3 sessions of the online trial, even with a coach. So that's pretty minimal exposure to an intervention. And the other thing was that people who had the intervention, they used 3 appointments as opposed to 4 appointments with mental health services. And also they had fewer, they made fewer phone calls to mental health service, and they made fewer phone calls and appointments to the GPs, to the family doctors. We only managed to recruit 63 participants. We're now repeating this trial in Canada. I nearly said Australia. It doesn't have weather like this in Australia. So we're doing a Canadian trial of that. So because of this particular context, what we're doing now is we're offering this to people on the waiting list for the MOOD program here. The MOOD program gets anywhere between 50, depending how you count it, anywhere between 150 to 150 referrals a month. And there's 3 people and a dog in the MOOD program. When the dog goes on holiday, you're in trouble. That's one of the reasons why there's waiting lists. And so we're offering this treatment on the waiting list to people. We've recruited 84 people so far, so it's bigger than the New Zealand trial. Interestingly, they're not as depressed as people in the New Zealand trial. But we've got much better adherence here. About 2/3 of people actually complete the program all the way through. I can't tell you what the results are because we haven't finished doing the trial. We'll get the results later on this year. That may be another talk. But what this tells you is about integrating these sorts of treatment into current models of care. So maybe one of the things in the future would be for family doctors, instead of referring straight to here, for instance, they could refer to an online therapy with a coach. Yeah, which might help with some of the access issues. Yes, quotes. These are some of the quotes. So I can't tell you the results, but I can tell you some hand-picked quotes which tell you how good the treatment is. So this is, for some people, they find it's the bee's knees. So this lady said, "The journal is my mirror. In my 56 years, this is the first time I'm seeing myself inside and out." And she's just working her way through a computer program with a coach ringing up her occasionally, just saying, "How you doing?" Some people they really buy into it. This is somebody else. "I'm grateful to be part of the e-Therapy program. With the guidance and support from my husband, you and the team, all my family members are seeing a huge change in me. I'm putting things behind me and moving forward. I'm looking at the positive. I know I'm not alone in this world. I'm so grateful to be alive and so grateful to be working with you. Yeah. Hey, it's just a computer program, but for some people, really buy into it. It's really great. Yeah. We'll see if that works for most people. Ask me in August. Here's another example. This is the original British version. It's called Beating the Blues. This is a for-profit model, so they actually sell licenses to use this. One of the reasons for mentioning it, you can probably look it up online and see demonstrations of it. If you just put Beating the Blues into Google, it'll get to this. And they've got it in lots of different versions now. One of the versions they have in British Columbia is that instead of having online therapies, they have a workbook, and based on Beating the Blues, and family doctors can refer you to this workbook. What they'll do is they'll send out the workbook. You receive the workbook in a CD. It's got the videos on it, and you get a coach who rings you up as well. So it's the same idea, but with the workbook. Clearly not as technologically sophisticated in BC as here, but they're just moving that onto e-therapy now. And people really like it in BC, apparently. Get a lot of good feedback. This is just an example of one of the trials that was done with Beating the Blues. Beating the Blues is one of the first treatments off the block. It's not as interactive as some of the later versions, developed by a mate of mine who's now Professor of Psychiatry in Glasgow. That's probably a good thing. But he developed this program, and again, he did a randomized controlled trial, and you'll see here, the black line is people who didn't get the treatment, who just got treatment as usual in British primary care, and the bottom line is people who got Beating the Blues, and you can see that they did better. And this tells you something about the components of Beating the Blues. It's fairly standard cognitive behavior therapy stuff. So activity scheduling, problem solving, and there's various cognitive components as well, which is basically getting people to record automatic beliefs, automatic thoughts. And this comes with a lot of a video with people with very English accents on it, which always makes people laugh. You're not from England. No, they're standardized workbooks. It's one of the downsides of them. It's a real live person who needs to eat and drink and give me a hard time. No, it is, and I think that's what makes the difference. Because I think some people have tried just doing automated reminders, and they're not as good. They improve things a bit, but not as good. Yeah. Really good question. In BC, it's paid for, the provincial government pay for it. Here, they're on a research grant. So that's one of the things to work out with technology. Is if you look at the budget for this hospital, for any hospital, there's no budget line for e-health or technology. It's not explicit. Maybe it should be.
Fundraising.
Yes, crowdfunding. Have you got some money? Because I know where to spend it. No, seriously, we're about to start a crowdfunding thing to finish this off. That's another good question, because it comes from a whole other theme of research which I've been doing. But in this particular example, this particular study, they're a social worker, very good therapist, very good social worker, and one of my roles is to stop her doing therapy because she's just coaching. But I think the next step in this is of course getting peer coaching. Yeah, I think that's one of it's the bit that people haven't focused on in this area. People often focus on the technology, But I think that the next step in the whole e-therapy and coaching story is going to be focusing much more on what the coach does and how they're trained. And I think one of the things I want to do in the next few years is start doing peer coaching. Because I don't think you need to have an expensively trained mental health professional to do this. You need to have a setup where people are well supervised and well supported, but I don't think you necessarily need an expensively trained health professional to deliver this, which again makes it more attractive and helps improve access. If you want to find, this is the best repository that I know of online therapies. This is from Australia. This is the website. So it's www.ehub, Australian National University, which is in Canberra. Don't go to Canberra. EDU, educational. It's a university. AU, Australia. And they're Australians are actually saying welcome. Well done, Australia. Also, there's also a Facebook page you can join, which tells you about current developments in e-therapies and gives you access to e-therapies. Beacon is an online repository for all sorts of e-health online therapies, not just for mental health, but for other things as well. That's one to go to. I'll talk about Mood Gym in a minute. Blue Board and Blue Pages are, I think, peer-to-peer. Do people know about the Big White Wall? You don't know? Do you know about the Big White Wall? Big White Wall is it's like a giant big white wall where people can post messages, and it's like a peer support thing for people with mental health. It's a moderated thing, and it's gone down. It's really big in the UK, and this is the Australian version, Blue Board. eCouch. I can't read it and I can't remember it, which probably means it's for youth. It's for young people. Young people can read that. I can't. But it says eCouch, and I think that's the youth version of Mood Gym from memory. Mood Gym was one of the first online e-therapies off the cab rank. It's now got 500,000 registered users, and it's being translated into Chinese. So that will now go up to 500 million registered users quite soon. It's an online CBT workbook. So it's a workbook. Doesn't really use videos. Well, the last version I saw it didn't. But the reason I talk about this is because it's a good repository. It's a good one-stop to find out about what e-therapies are out there, and it's a situation which is constantly changing. So get somebody else to record what is actually changing. This is what Mood Gym looks like. They call it a training program. And talks about feelings, thoughts, unwarping. They're Australian. And this is an example of the sort of stuff on Mood Gym. So it talks about linking feelings and thoughts and so on. And there's various quizzes that you can do, but that's about as interactive as it gets. But still, people have done trials of this and showed that it worked. If you use this, you're less depressed than people who don't use it. It's not rocket science. I'll tell you about rocket science. Problem-solving therapy, which was essentially the therapy behind the journal. They've actually developed that. NASA have taken that and developed that for long space trips to Mars. Because the one thing that's going to screw up long space flights, and one thing which has screwed up space flights in the past, is the human factors. Is people getting depressed, or the other thing is disagreeing with mission control. So they've actually developed e-therapies that you can use on the spaceship whilst you're on your way to Mars, because you haven't got anything else to do, to help treat depression and also for conflict management. So that NASA have been investing in online e-therapies of problem-solving therapy and conflict management. So it is rocket science. Sorry. There are some problems with the research in this area. A lot of the studies have been done on people recruited over the internet. and you don't actually know who these people are or whether they are the sort of people that would just get better anyway, or people who would go to a health professional. There's high dropout rates, which I've already mentioned, but it's also comparable to face-to-face therapies. And there's little information about acceptability or feasibility, which I'll come on to later on. I don't know how many people know about NICE. NICE used to be nice, but it's not as nice as it was. It's the National Institute for Clinical Excellence in the UK, and they are the world's leading producer of guidelines for medical conditions. If you want to find out how you should be treated, go to the NICE website and download their guidelines. Yeah, and it's not just mental health, it's everything. They are because they're well funded, because it's a government funded body, there's nowhere else in the world who's producing guidelines as rigorously as they are. And all the stuff they produce is free and it's online. So if you want to find out how to be treated and what your treatment should be, I'd access that. And what they've recommended for people with mild to moderate depression is this. Is either guided self-help, structured group physical activity program, or computerized CBT. Okay, so NICE now reckon the evidence is good enough for them to say that for people with mild to moderate depression, computerized CBT will do the job. What would that look like? What it looks like is this. What they recommend is explanation of the model, encourage tasks between sessions, use thought-challenging and active monitoring of behaviour, which you can do with smartphones. I'll talk about that in a minute. Thought patterns and outcomes. And the other thing interesting they're recommended now is be supported by a trained practitioner, doesn't say health practitioner, trained practitioner, who typically provides limited facilitation of the program and reviews progress and outcome. That's coaching. And typically it takes place over 9 to 12 weeks, including follow-up. Okay. So that's the standard of care which NICE is now recommending for people with mild to moderate depression. How does this fit in with what we're doing in Ottawa? In Ottawa, we're for triangles. We're really big on triangles in Ottawa. And what we are trying to do as part of a project to both improve access and to decrease suicide and self-harm in the city by 20% by the year 2020 is to help primary care professionals access mental health better than they do at the moment. So we are trying to create a virtual mental health clinic, which has 3 floors at the moment. First floor is information, resources, guidelines. We've already launched this, directed at primary care. I need to say this is based on an existing site called e-mentalhealth.ca, which if you haven't come across it, I'd use it. It's been set up by Mike Cheng, who's a psychiatrist, child psychiatrist at CHIO, and it's been up and running for some time. And we've, with him, have now created a shadow site directed at primary care. And what e-mentalhealth.ca does, it contains a lot of information about local services, how to refer there, what's available, what's not available, as well as lots of information about different disorders. It's a very good starting point for care. It gets 40,000 hits a month. Yeah. So this is the primary care version that we're trying to launch, we're trying to create. The next level, so this is really stepped care, is having e-consults. So that's primary care practitioners emailing psychiatrists questions about treatment. E-health coaches, which I've talked about, and e-Therapies, that's the second level. And the third level is around getting referral brokerage, because at the moment it's a nightmare for both patients and primary care physicians to refer anybody to mental health at the moment. So we're trying to make that easier for everybody, which involves getting people to work together. So we're looking forward to doing that. So that's where e-Therapies may fit into some sort of stepped care model. And this is just an example of the sort of information which is available on e-mental health. You can see the different partners there, so the Royals there, CHIO's there, who've all contributed to this. Of course, technology is not just related to online e-therapies. I don't know how many people know Sparks. And I'm not talking about the 1970s pop band. Anyone name their greatest hit? You can tell your age there. I can't remember. And if I can, I'm not admitting to it. But this is the online game Sparks, developed in Auckland in New Zealand, but now available worldwide. It's a game which aims to teach teenagers the principles of cognitive behaviour therapy. And you go on several islands, and you have to work. It's a quest game where you have to go through these different islands and abolish NATs, which are I can't remember what NAT stands for. Yes, it's negative automatic thinking. And you select an avatar, and you can dress it how you like. So you can dress up as a Maori warrior. You can dress up as a psychiatrist, just there, a nurse like that. You can personalise it quite a bit, and you basically go through this quest, and you learn skills as you game. And I think it's one of those things which I don't think it's been explored well enough with adults as well. Is the power of games to teach you things. The thing is, it's very expensive to develop these games and complex. And as soon as you've made one game, it goes. The technology moves on. So this game was originally developed to be rolled out on CD. Yeah. So you couldn't download it anywhere. But by the time they'd shown it worked, nobody had a CD player anymore. Which is one of the problems with technology. It's moving on so quickly, by the time you've shown it works, you can't use it. And that's been a real problem with Sparks. Smartphones. Lots of people have smartphones. And there's lots of things you can do with smartphones. Of course, nobody really accesses the internet anymore from desktop computers. It's all done by mobile phones. And mobile phones have they do lots of things. And as you know, there's hundreds of thousands of apps for phones. There's tens of thousands of health apps. And there's thousands of mental health apps for phones. I'll show you some in a minute. I'll show you some. They change almost daily. And one of the difficulties is nobody knows if they work. Nobody knows about the quality of them. And they're not particularly regulated. Regulation is a really difficult area here in this situation. And there's also issues with privacy, which we're struggling with at the moment, just getting this particular trial through an ethics committee. So what we're planning on doing is using a smartphone to supplement face-to-face therapy. Because when you do face-to-face therapy, you only see somebody for an hour a week, if that. If the rest of the time they're not with you. How can you hope to produce any change if you see anybody for just an hour a week? Well, actually you do. We want to see if it's going to produce any more change by supplementing it with a smartphone. And this uses a particular app called HS. And I'll just tell you about this app because it just tells you something about what apps can do these days. So you have the ability to create a support network, both professional and personal. You have the ability to have, there's messages here. There's lots of audio and useful information you can put here, as well as things like games to distract you. If you talk to suicidal people, one of the things they'll tell you is the value of distraction. And it's one of those things I don't think, again, is explored enough in the literature on suicide. But we're going to put some games on there which will help people, like Tetris. It's not complicated. But some of the user feedback from service users has been that having something simpler, a game like that, is actually really helpful to distract people. It keeps you breathing. Sometimes your sole job is to just keep breathing. And Tetris, some stuff like that is good distraction. So we can have and we can put things on here on how to relax, that sort of stuff. The really clever stuff is when it starts using the mobile phone's inbuilt capabilities to start giving you feedback. So in this bit, you can have daily check-ins to your therapist, and the therapist opens up their computer in the morning, and there's like a dashboard, and you can see all the people that they are involved with, who are collaborating with. You can see who's getting worse, who's getting better. So there's that real-time feedback. It can also tell you, because the smartphones have GPS, I can tell you several things. One of which is how active people are, which is important if one of the things you want to do is get more active. Exercise is quite good for depression, so you can monitor that. The other thing it does is because it's got a GPS in it. It can monitor your location, and if you go near a location which is risky for you, so if you go to a pub where you get drunk and you feel suicidal and you act like an idiot, or you get close to a high-risk spot like a bridge, the phone will automatically send you a warning message which you can personalize. So if you're going to Joe's Bar, for instance, and the last time you went there, you got drunk and you went home and you're a complete idiot in front of your family, when you're sober, you can personalize a warning message which says something like, "Don't go to Joe's Bar because last time you demonstrated what a rubbish dad you were to your daughter," maybe with a picture of your daughter. So when you walk towards Joe's Bar, when you get within 100 meters, you automatically flashes up that warning. Yeah, so clever stuff like that. And really, it's limited by your imagination about how you can use these things. So we're wanting to see if this is a useful supplement to problem-solving therapy. And problem-solving therapy is about helping people learn a skill. And we'll alter this app so that it integrates with the face-to-face therapy. So it'll have things like how to come up with a SMART plan, which is specific, measurable, achievable, relevant, time-limited. As with the journal, we'll send reminders, set it up so that people can have reminders that this is when they said they were going to do things. And hopefully we should be starting the pilot trial sometime this century. But hopefully the next few months, and then we'll start the trial towards the end of the year. Here's various online apps. The reason I've selected these, and I could have selected loads, is that these were ones which are recommended on the NHS app library, the National Health Service app library in the UK, which if you now go and look for it, it's been closed down. You know why it's closed down? It's because nobody could actually guarantee that these things worked. They had all sorts of apps on their website, and one of the issues was, why these apps? Why these in particular? Is there any evidence that they actually work? And there's only actually 5 which they had evidence that they worked. So there's Big White Wall. There's Mood Scope, which is about monitoring your mood. CBT iCoach. That wasn't on it, but I'll talk about that. Happy Healthy, which is, I think, a mood and meditation app. And Work Guru, which is managing stress at work app. And with all those 4 or 5, there's good evidence they work. This is CBT iCoach. I've got this one on my iPhone. It's developed by the Veterans Affairs in the US, and it's quite a sophisticated app to help manage your sleep. It teaches you good sleep habits and sleep hygiene, and there's good evidence that it actually works. It's free. All these apps are free, I think. What else? Virtual reality. I actually tried a virtual reality thing for the first time the other night. It was just a Samsung phone which plugged into an attachment which would look just like that. I don't know if anybody's used it, but it's amazing. It's just on a mobile phone. You just click the mobile phone into the front of the headset, and virtual reality. Amazing. The Canada chair in virtual reality therapy is based in Gatineau, and he's been doing a lot of research in exposure situations for people with anxiety and phobias, which is a very obvious place in which you could use virtual reality. You could also imagine using it for assertiveness skills training, training people in other skills. Google Eyewear. This is augmented reality. You could envisage a time where people with psychotic symptoms might be supported with augmented reality, if you like, where on the Google Glass up comes a description of what something is, which might be a counterbalance to some of the things which are going on in their head. People might find it quite reassuring. So they provide reality-based feedback. Robots. The robots on the left. Paro, based on a Canadian fur seal, I'm told. Robots can help. One of the main places that robots have been tried in mental health has been actually in nursing homes. And they've used robots like this and robots like this. And they found, again, in reasonably sophisticated trials, that they help reduce aggression in nursing homes. And they also help people to remember to take their tablets. And the other things you can do, you can do mind exercises and communication on these robots. In New Zealand, there's a particular little health authority, and it's really small. It's called GORE, as in the bits of the body which butchers don't use. So it's called GORE. And it's a little health authority in the middle of the South Island. But they're really banging ahead with using robots in the community. They bought, I'm going to get a picture of it, but they bought a little robot which sits on your desk or sits by your bed at home, and they bought about a dozen of these, and they've been handing them out to older people in their community who really like them because they help to remind them to take tablets. You can Skype on them, so you can Skype rallies. They can do mind exercises. There's all sorts of cool things that you can program into them. In many ways, they're no more sophisticated. In fact, they're less sophisticated than a smartphone. Because they look like a robot, there's something engaging about them. And this is Paro, who is a robot and responds to how people treat it. So it's a bit like, you can buy these. If you want one, it costs, I think, a couple of $1,000s now. You can buy them online from Japan. But it's you've heard of animal-assisted therapy. This is animal-assisted therapy without the poo. That's exactly what it is. Brain implants, not quite there yet, but we're getting there. They're using brain implants in Parkinson's, which is just a simple wiring problem. Big data and social media. Just talk about one part of this. You've seen Tom Cruise's Minority Report? It's a film which is based on a science fiction novel where they could predict who was going to commit a crime. So pre-crime, that's what's here. So he arrests people before they commit a crime because their prediction models are so good. In the film, of course, the plot line, of course, is that he gets fingered as somebody who's going to commit a crime. It's an interesting film. It's not one of his worst ones. But of course now we don't have pre-crime's a reality. This technology is already being used. So what happens now is that social media gets scanned, and spy agencies are now using this to predict who's going to be a terrorist. And I don't know if you remember the people who were planning to blow up a train on Via Rail in Toronto. One of the bits of evidence that was used against them was from social media, which had been intercepted by spy agencies. It was literally a pre-crime thing. So that's now a reality. But you can use the same technology, of course, to predict other behaviours. So somebody in the University of Ottawa just got a grant last week to see if they could predict who's going to kill themselves by scanning social media. The technology to do that is relatively trivial. The difficult bit is knowing what to do with the information and the privacy issues around that. But this Minority Report is now mainstream reality. So what are some of the problems with the new technologies? One of the problems is it could reinforce inequalities. I'm not going to go through all of these because time is pressing. I've actually touched on a lot of them. So in Canada, if you look at this slide, in the lower income households, only about 6 out of 10 have access to internet at home, whereas it's nearly everybody in the higher income households. And yet, of course, it's low income people who most need these treatments. So it reinforces a digital divide. It's like only the rich can afford it. And that's figures from 2012, Canadian figures. And the other difficulty is integrating these into the Canadian health system. The Canadian health system is remarkably untechnologically savvy compared to other health systems. And it's not me saying that. This is figures from the Commonwealth Fund. So this is the sort of Netherlands, Norway, New Zealand, to some extent UK. This is doctors' use of electronic medical records in their practice, 2009, 2012. So virtually everybody in those 4 countries. In Canada, it's got up to about half in 2012. And this is just electronic medical records in family doctors' practices. Don't know what happened in Switzerland, but they're catching up. But in comparison to other countries, Canada is technologically not that sophisticated in the health system. And there's lots of good reasons for that. And in some ways, it does lead the world. So in telemedicine, it's really good. Technology, not so much. So when I was in New Zealand, if I saw somebody in the emergency department in the hospital I worked at, if I sent a GP a physical letter, they wouldn't know what to do with it because they've got nowhere to file it. It's all electronic records. So I had to email everything. Well, not had to. Emailing, it's just, why wouldn't you? And so as soon as I saw somebody, I wrote some notes and I just emailed them to the family doctor. And that was it. It's slightly different here. So it's one of the challenges in Canada is integrated technology into a system which is still got a bit of catch up to do. But I mean, it's catching up. The Mental Health Commission of Canada have produced a e-mental health strategy, which needs some implementation, but go to the Mental Health Commission's website. This is the one-page takeaway, and there's a document behind it which you can look at if you want to update yourself on what's happening. And there's lots of good Canadian examples of technological innovation. So in the future, if we're going to get technology integrated into healthcare, there's lots of really good opportunities. These are the sort of things I think which needs to happen in the area of policy. And none of it's about the technology. None of it's about the people, and it's about policy, and it's about money. So developing these programs needs to be person-centered, patient-centered. Patients need to be involved from the beginning in developing these technologies and rolling them out. When you develop an e-therapy, when you develop any technology, you need to give some thought to how this is going to scale up into a big scale. It's very different from doing a trial in 100 people to rolling it out in Ontario with a population of, 13.5 million. Yeah. So you've got to give some thought about how would this actually work on a big scale. It has to be embedded in existing quality assurance framework. So you have to be able to say that when you get something delivered as an e-therapy from the Royal, it has all the inherent standards and quality that you would get if you saw somebody face-to-face at the Royal. There needs to be research to actually demonstrate that these things make a difference. There needs to be knowledge translation and exchange. Most doctors don't know about e-therapies. So when I talk to family doctors, they don't actually know that the e-therapies exist, or this is where you could refer people for CBT and it's free, and they could do it now. Yeah, most people don't know it. So there needs to be something about knowledge translation and exchange. People need to know more about it. Clearly needs to be integrated with existing health and technological policy. At the moment it's not. And it's both health and technology. All the technology policy in healthcare, pretty much everywhere, is around either electronic health records or what computer systems to use in hospitals. It's all about hardware. There's not much about the software or about treatments using e-therapies. It needs to integrate with existing health services. Where does it fit in the stepped care approach? Because clearly some things like virtual reality, well, up until recently, were only really available in specialised centres. So who do you offer that to? Do you offer that to somebody when they failed face-to-face therapy? Not failed, when they haven't responded to face-to-face therapy? Or do you offer it to people before they have face-to-face therapy? And how does it fit into existing models? Is it sustainable? Big issue. Technology is changing all the time. And it's one of the difficulties of doing research in this area, as I've said. By the time you've tested something to show it works, it's out of date. And there's big issues around privacy and security. There's personal health information, personal identifying information. Who has access to that? Where is it stored? It's not an insurmountable problem. People store their personal bank details online all the time. Health isn't any different to that. So, tremendous opportunities for doing things differently, but it's not all about that technology. Technology is just an aid to helping alleviate the burden of mental illness in the community, which is what we're all about. So, thanks very much. Do you have any questions or comments?